Hi everyone, my name is Qais Fadada. I follow Dr. Shamas at his foundation, Midwest Cardiovascular Research Foundation, Davenport, Iowa. We have this case management of thrombosed contralateral common iliac vein secondary to jailing by a wall stent extending into inferior vena cava. Nothing to disclose. So a 37-year-old lady who presented with swelling involving the right lower extremity for 5 days duration. The swelling was extensive that the patient started complaining of numbness and severe pain. Of note, 2 years prior to this presentation, the patient had DVT involving the left common iliac vein and required a placement for a wall stent. She was on anticoagulation with Coumadin, but this was interrupted for back surgery 1 year prior to this presentation and never resumed anticoagulation. Patient has positive family history for DVT, is an active smoker, no recent travel. On presentation, Dopplex ultrasound showed extensive DVT in the right lower extremity from the popliteal vein up to the common iliac vein. This image is the venogram after obtaining access from the ipsilateral side. The right side here is the right side of the patient. As you can see, the contrast almost stops before it ends up to the inferior vena cava, showing the extensive DVT. So the procedure, after obtaining popliteal vein access on the ipsilateral side, patient was in prone position. Destination sheath was advanced up to the area of the thrombus. The wire was carefully advanced to make sure it doesn't get into the contralateral stent struts, and IVUS was used to confirm wire location being outside the contralateral stent. Given the extensive thrombus, angiojet embolectomy with power pulse spray was used. TPA was applied with good resolution of the thrombus burden. Dilation with a 8 millimeter diameter balloon at 5 atmospheres. This was followed by a 12 millimeter balloon at 4 atmospheres. This image here shows the balloon dilation of at the ipsilateral common iliac vein. And then IVUS image, as you can see, the stent here is the contralateral left common iliac vein stent. Wire was outside that stent, and it's important to make sure of that. We decided to place a stent. The choice was to pick a wall stent, 20 millimeter in diameter. This was placed in the iliac vein adjacent to the contralateral stent, as you can see in the image below. This was dilated with a 14 millimeter balloon. Immediate decrease in the pressure from 48 in the venous compartment to 18. Angiography has confirmed excellent flow, and the patient was discharged on aspirin and Eliquis. 1 month follow-up in the clinic showed the resolution of pain and swelling. This here is the final venogram. You can appreciate 2 stents opposing each other, and good venogram flow. So what this case highlights, it is important to note that jailing from a contralateral iliac stent can occur, can result in an extensive thrombus as in this patient. It's important also to highlight for the interventionalist that the use of IVUS is really helpful, not just to guide the stent size as in this case, but also to make sure that the wire is outside from the contralateral stent struts, as this can complicate the procedure if any mistake happens. Also, the choice of stent, we noticed here that despite the new release for the venous stents and the FDA approval for different brands for those stents here, the new stents, the nitinol open-based design, are much stronger in their radial force compared to the wall stent, and this might compromise, if we picked any of those stents, the contralateral stent that's placed there, and this has to be kept in mind. Maybe we hypothesize that if the patient did not have a wall stent in her left common iliac vein, it's possible that if a new stent or one of the nitinol new stents was placed instead of the wall stent, maybe this would not have migrated more proximal to the IVC and would have prevented such a presentation. I welcome your questions, and thank you.